Hello and welcome to this, the Improving Healthcare webcast and webinar. Now, it's a series brought to you by Develop Consulting, a trusted healthcare improvement consultancy, and they work across acute, primary, mental health, community, you name it. Now, in these casts, we really do hope to give you some genuine insights and practical change for healthcare. Now, each episode we have new guests, and we're able to really talk to those healthcare leaders about what they're implementing to deliver serious, genuine and lasting change. My name is Darren Jones. I've been a strategic director in the NHS for many a year, too many to mention. And today I am joined by guests, and we're going to talk about what does a car factory really have to do with your GP surgery, your hospital, your mental health service? Yes, we're going to talk about what Toyota can teach healthcare. Now, on the surface, nothing. But look a little closer and the answer may well surprise you. Today I'm joined by Steve Boam. He's the CEO of Develop Consulting, and he's Toyota through and through. He trained and worked there for many years, both in the UK and in Japan. And we've got Jeremy Butler. He's Executive Director for Transformation at Imperial College NHS Trust down there in London. He's also the ex-CEO of King Edward VII Hospital. Now, rather than giving the full introduction to both of them, I've given a little teaser, but I'm going to let them speak for themselves. I'm going to start with you, Steve, because this is Toyota themed. Tell us about yourself. Tell us a little bit about Toyota. Tell us why it's relevant to healthcare.
Yeah, thank you, Darren. So as Darren said, my career started at Toyota. So I was fortunate enough to work in the UK for many years and then go to Japan for 2 years to work one-on-one with the Japanese management. And the things we were doing in Toyota 20 years ago now, the rest of industry is still learning from and trying to catch up with, let alone the NHS. So we'll get into more in the podcast later on, but Toyota is a philosophy, it's a methodology, it isn't a set of tools. And if you apply that from top to bottom of your organisation, then you've got a really good chance of really transforming, not just doing point projects.
Jeremy, tell us a tiny bit about yourself. You've been around. And also, can you tell us how you see Toyota as relevant to the work you've done? And also just a little bit about working with organisations like Develop Consulting that really know about Toyota ways and bring that improvement, and how you've been bridging that.
Yeah, thanks, Darren. So I started my career in manufacturing, and some years ago, I was faced with a small, medium enterprise, had a lot of work in progress. Short shipping, it's very good quality, but short shipping deliveries and running on the back foot, no stock. And I really didn't know what to do about it. And I was showing somebody around, a customer, and we got away with it because our quality was great. We weren't making any money. And he said, "You need to get into lean." I said, "I don't know what you mean." I was whatever I was in my early 30s, hadn't heard of it. And I read a book called Lean Thinking, which he recommended to me. And it just blew me away. And there was a case study in there of the company in the sector that I was in called Showa Foundry in Japan. And I basically bought a dozen copies and spread them out to my management team. They said, "We're doing this." And it was do that or go bust as well, which is a wonderful motivator. So fast forward, and the principles that were applied then of understanding where the waste is created in the value chain from the order to the customer receiving it, or rather you getting paid, understanding where the clag is in that process and getting rid of it, is fundamentally applicable to manufacturing or any Subway sandwich production or a GP clinic or whatever. And they're the same principles that I follow in my work today. And I recently was running a hospital, a small hospital, exactly the same principles there. Too much time spent on the wrong things, lack of focus on key deliverables, and then all about people underpinning that. Do the people know what they're doing, how they're doing it? Are they trained accordingly? And all of that. So, yeah, I found that a liberating knowledge over my career.
Thanks, Jeremy. Steve, Jeremy just said that it's going to make lots of healthcare people go, "Oh, no, humans aren't sandwiches. We're not Subways." Can you just explain and really just identify why the whole Toyota thing is not just a system, it's a philosophy, and that's why it's really, really relevant to healthcare?
Yeah, in Toyota, we used to talk about two things. TPS, the Toyota Production System, tools and techniques for improving quality, improving flow, improving the way we manage things, from projects and new vehicles through to processes. And as Jeremy said, continuous improvement and taking out the waste. But we used to talk more about the Toyota way. And the Toyota way is fundamentally, when you boil it down, two things. It's about people and it's about process. And it's about motivating your people, teamwork, partnerships with your suppliers, and really developing your people, continually developing your people, training your people, giving them the tools and the skills to do the job, and holding them to account for the task at hand, but also how to improve the task at hand, because they're the local experts. They're the people that do the job time and time again, especially at the front line or the shop floor in a factory. Process is about setting up processes that are repeatable, that you can train people in easily, you can audit against, and deliver an outcome, whether that's hand off to a next process or whether that's to the customer across, as Jeremy said, the whole value chain, or pathway as we talk about in healthcare. So the Toyota way is fundamentally different to TPS, but TPS is tools. The Toyota way is fundamentally a philosophy about how you manage your people, your processes, and bring it all together to get the best outcomes, repeatable outcomes for safety, quality, delivery, and cost.
Jeremy, you've read the book. In fact, you bought lots of books and gave them to people. Is there something a little bit different about just reading a book and trying to implement it than actually working with people that have lived and breathed it? So, I mean, you've worked with the guys at Develop Consulting in various of your roles over the time. Is there a reason for that? Is there something that brings, because this is a philosophy and not necessarily just as easy to learn from a book?
Yeah, so 2 points, I suppose. One is that I didn't just give books out. We actually did it. I created the first Kanban board on the shop floor. I painted it myself, and I ran all the training out of books myself. So I essentially came completely blank canvas, not knowing it. Then you stumble across people that actually know this stuff and have it ingrained in their DNA, like Steve. And it's wonderful because in any given scenario, that individual has seen that situation, and they have that kind of seasoned mentory coachy style that they bring to a shop floor situation. So not just necessarily telling if they need to, but what the other really nice thing about the people I've worked with over the years is the coaching style. So how do you think we might do this, or what do you think might go wrong with that? Even if it's screaming out that that's not a great idea, they will get the individual to ponder that. And just to echo Steve's point about the people, that people aspect, I think it's really interesting. The Americans sought to copy Japan's post-war revitalization by putting in their own, food production system and all the rest of it. But I think they've often missed the people aspect of it and the deep respect for the individual, and making their life easier and simpler. So yeah, I think that human piece that the experienced people have, the kind of deep knowledge and fundamental principles, goes a huge way. There's a story, I wasn't there, I was told the story, but I just love it, of some kind of Kaizen project that was happening in Japan, and the guru, the sensei or whatever, the older gentleman was there, and he's staring at this wall in this factory, and he said, why is this wall here? And they said, well, we don't know. I mean, it's the wall, and it's a wall, so that's what it is. And they kind of wandered off, and they turned around, and he's jumped on a forklift, and he's put a stillage on the forks, and rammed the wall, the breeze block wall. And he's rammed it to knock it out, because he's like, no wall. We didn't need the wall gone. And that kind of attitude can only come from being ingrained. So I'll stop there.
No, it's really interesting because, we keep going back to people, and let's face it, the NHS is all about people, not just our staff, but our patients. They're actually people. They're not Subway sandwiches. So the fact that it's embedded in people, and I think from my experience, I've seen a lot of people misunderstand that, and they do think it's all about systems and paperwork. Mm-hmm. It's actually the exact opposite. Let's be direct about this, right? The NHS needs improvement. Health Secretary says so. What are the fundamental pressures and challenges that adopting some of these Toyota principles, adopting this philosophy, will really rapidly get results on? I'm going to go to you. Actually, I'll go to you again, Jeremy. You can start with that.
Yeah, thanks.
You're in there.
So, very relevant question, Darren. Thank you. You've got to fundamentally have, and I've experienced this. You've got to have the buy-in and the air cover and the hunger from the very top of the organisation. NHS entities are notorious for having lots of different stakeholder groups. So clinicians have their Royal Colleges, you might have a trade union, you might have a staff group, whatever. You've got a lot of stakeholders. And really, none of this is particularly complicated. It's just difficult to kind of get it done. You've got to be able to align around the problem that you're seeking to solve. And that has to be driven and understood and celebrated from the very top. I'll give you an example, patient flow, length of stay. I went into a trust once when I was independent, and they had 4 different measures for length of stay. So, I mean, A, which one are you going to focus on? B, they never didn't really care because they had these different measures. It just wasn't the most important thing for them. Yeah, in a different forum, it would be, our patients are here too long, we need to do something about it. You have to focus on the metric, and then if you measure it, it's probably going to get improved and acted upon. And that elegant focus from the top, what are we here to achieve and what are we doing about that? And then to maybe not relentlessly, it's probably too strong a word, but to consistently pursue that. And I think, what gets measured gets done. That's the key. And that is tricky because in the NHS, you've got safety, patient care, pressures from the centre, a wodge of funding pops up, but you've got to spend it by the end of March, but you can't spend it on capital. There's all of this kind of these weird rules around the NHS. So I think fundamental focus at the top about what are we seeking to achieve here, and then keep going at it.
Steve, lots of our viewers and listeners will be going, measure it, metrics. At one point, I can't remember how many 100 metrics there were around the NHS, and they were all going south, and people felt we were measuring too much. Is there something about where the metrics come from and why they're used and how they're used, rather than just metrics for metrics' sake?
Thank you, Darren. Yeah, measurement drives behaviour is a famous saying, and what measures gets done. So to Jeremy's point, if we give people conflicting measures, they either won't do anything or they'll pick the one that's most comfortable or most relevant to them. We've also got to change the language as you go down an organisation, because at a chief exec level in a hospital, for example, the measures upon them to balance the books, maintain patient safety, quality, maintain a workforce, a suitable level for safety, etc., is very different to a ward level, where they've got to process a number of patients in a set time, depending on the pathway and the length of stay. So it's about measuring people in something that they can affect and can drive. So length of stay is a good example. If Mrs. Smith is coming in for a 7-day length of stay operation, how do we maintain or manage Mrs. Smith across those 7 days so that she leaves on 7 days better for the patient, better for the staff, better for the hospital because we free up the bed, and the financial envelope as well around that patient. So, but giving somebody a 7-day length of stay, they can do something about that. They can plan around it. They can measure it, manage it. Giving them a financial target for the trust, they're a smaller player in a bigger machine.
But Steve, I'm going to press you on this because we've seen it time and again. Sometimes what gets measured gets played, and we play the game, and then it's not actually what's good for the patient. So how does that Toyota philosophy, rather than just measuring for the sake of measuring and gaming the system, which we know happens, how does that change it fundamentally, and how does that feed in?
So Toyota is very transparent with itself and its supply chain. We used to talk about a no blame culture. So if the KPIs or the measures aren't good, we declare it, but we declare it with an action plan to sort it. That doesn't always transpire into various parts of the public sector, other industries, or the NHS, because people see it as a failure or think they're going to get into trouble for raising something that's away from target or isn't good or is a risk. And that's back to Jeremy's point about culture. If the culture is set from the top that we want to find problems because we want to solve problems, because we want to strengthen the organisation, make it safer, better patient care, better patient quality, better for staff morale, then that culture will seep down through the organisation and people won't be afraid to declare a measure that's off target or a risk. So Toyota was all about finding things before they happen. So near misses to prevent accidents is a good example, or finding issues with the products or the car or the process before it became an issue in the field, and containing it and managing it at source, rather than letting it blow up into a big problem that then costs a lot of money and time to fix. The NHS is not always there on that journey yet, because ministers set targets, the centre sets targets, and people are held to account. A great example is A&E. So previously, 4-hour targets were imposed, which I think was a good measure to focus people on, we'd like to see patients in less than 4 hours and let them wait less than 4 hours. But it was a blanket target of everybody must be seen in 4 hours. Well, if I'm a minor patient, I might be seen in an hour. If I'm a complex medical, elderly, major patient, it might take 8 hours with all the diagnostics and things. So it should have been an average of 4 hours, and we managed the minors and the majors to suit. One of the behavioural things that did happen, though, is because we can't see everybody in 4 hours, we invent secondary processes like medical assessment units or surgical assessment units. So we pass people through in the 4 hours, but we pass them on to another department. So we achieve the 4 hours, but we've not really achieved the actual result for the patient, as an example.
Jeremy, have you found in your long career in this, particularly in the NHS, that by adopting this Toyota principles, whatever, you end up with metrics that actually help the patient rather than short-term glorify the organisation? And actually, in the long term, that's better for the organisation.
Yeah, I mean, I understand a slightly roundabout way. If you are clear about what the problem is that you're seeking to solve in the first place, then patient experience, and organisations have done this. For example, the Institute for Health Improvement have talked about patient experience, staff morale, value for money, system working, and I think they've added a fifth one now, which is equity. But if you get into the problem, typically with a hospital setting, acute setting, it's about the patient. It's about their experience of the organisation or the actual clinical outcome. So if you're clear about that, then you're clear about where you're trying to get to. Something that I talk about at work is process versus outcome. So for some reason, there seems to be people will feel that they've done something value adding when they've done a process thing. And my challenge is, what is the result of that? What is the impact of that? And how does that benefit, going back to the people or whatever, the problem that we had? So I think it keeps you grounded to be able to say, how will this benefit the patient? Wait times, 4 hours is a pretty cold measure. The reality is, there was one in the paper the other day from somebody saying the NHS is broken. I waited 12 hours and then I wasn't admitted. I was sent home. I could have been sent home quicker. Yes, they could. When you dig, it comes down to staffing models, actually, not just people, but the staffing model, the teaching model. The junior doctor needs to look at them, not a senior doctor. Senior doctor make a really quick decision. Junior doctor will take longer and then have to validate, but they've got to do that to learn. So the irony is a different setting.
And Jeremy,
I'll stop there.
Staying with you, Jeremy, on this. So when you look at different trusts you've worked with, what's that real difference between this embedded philosophy of continuous improvement, of always doing the right thing, measuring the right thing, getting better, rather than it's some sort of bolt-on and a function over there that are going to go and get different improvement targets? How's that worked with you?
Yeah, it comes down to the behaviours and characters of the people on the front line. So they feel that they can improve the work they do. They care to improve it. They believe they can improve it, and they're supported by their immediate line manager. That, to me, is one of the fundamental building blocks of improvement work, particularly in a large organisation. They've got to care in the first place. And sadly, there can be instances where people think, well, there's no point. It's all a bit helpless. It's like saying, why should I vote? There's no point in doing it. You have to believe you can make a difference. And crucially, you've got to be supported. And just to make a slightly oblique point, that's why the PDR, or whatever people call it, PDP, your personal development plan or review or whatever, is so important in the workplace, because that should hardwire in not just the business as usual job you're expected to do, but aspects of that you might seek to improve, and how we liberate time for you to improve and maybe get some training and feel that you're part of that iteration. And if you have a slight nervous energy that this could be better, it's fine or it's okay, but it could be even better. That is the key. And when people have that beaten out of them, or they have managers that fail to encourage that or nurture that, that's criminal, because then you end up with a torpor at a shop floor level that won't help change stick.
So we've got a system and a philosophy that's very people centric, actually delivers results. How's it relevant to me, Steve? Just give me an example of why the Toyota shop floor is similar to a hospital ward. What are the parallels that strike you? Where are we dealing with sort of an identical problem, and how's the model and methodology really absolutely instantly delivered on that?
Thank you, Darren. So, so a hospital is a factory. Now, some people would disagree with me on that one, but an ED department is a factory, a ward is a factory, a theatre is a factory, an outpatient setting is a factory. So if you take the context of ward, as you've just described, we put patients in at one end and we aim to rehabilitate them, get them better, and send them home at the other end, or send them on to their next place. So that might be step down care, that might be care home, another, depending on the patient and the type of pathway. But it's a process and it's a factory. And what we do with the patient on day 1, day 2, day 3, all the way through their stay with us, in terms of managing their safety, managing the quality of care, the rehabilitation, the clinical care, and the communication to them and the families, is really important. So we could take absolute from Toyota's shop floor in the way they manage a car, the parts, the people, the teams, and arrange the teams, arrange the process to give the best care possible in the best time and the most productive way, etc., etc. So it's a great patient experience. It's cost effective because we've done it in the time allocated, length of stay. It's high quality care because we're spending quality time with patients to rehabilitate them. And often what gets missed is we spend lots of time doing other jobs rather than contact time with the patient. We were fortunate to write a program in 2006 called the Productive Ward, which identified early on that less than 40% of a nurse's time was spent rehabilitating patients. So 60% of their time was spent doing paperwork, chasing results, chasing medicines, chasing doctors for safari rounds, etc. And less than 40% was spent with patients. Well, we have to rehabilitate these patients who've had a major operation or, something go wrong with them, that in order to make them better, in order to get them well, fitter, soon, and out of the hospital. So there's absolute parallels between what you do on the shop floor, managing your parts and your process, to how you manage your people and your process within a hospital ward.
And I'm going to come to you in a minute, Jeremy, but I'll just say, Steve, I know you are taking a load of people from healthcare around the Toyota factory at some point. I think the Mini factory as well. So you sort of do that. But Jeremy, how do you find actually engaging people to understand what Steve's just said, that actually it is genuinely similar to the factory floor, and saying that isn't disparaging to the NHS or to patients?
The black box of clinical care that you do is your area. That is your domain, and I'm not going to get involved in that. But all the bits that lead up to that, and all the bits subsequent to that, I'm very interested in. Because that could compress time, that could take away waste. We could get there, we could get to the black box quicker, we could enable the black box quicker. And there's no harm in saying head on to people, our job here is to enable and facilitate the better delivery of healthcare, whatever that healthcare may be. We're not trying to do the job for you. We're not blurring into that. We're just dealing with the underpinnings that enable you release time to care, enable you to do the job. There's people talk about surgeons. Surgeons like to cut, so they enjoy surgery, and they get it when you say, we will give you more time to do what you like to do. Well, thank you very much. They're not looking to shirk cutting; they like it.
And it does sort of make sense, and I suppose it gets to that critical question of, what does world-class operational performance, excellence, actually look like in that healthcare context? Not in manufacturing, not in retail, not specifically in healthcare. I'm going to stay with you on that, Jeremy. How would you define or crystallise that?
Well, my challenge back is they're not that different. There's just the emphasis changes. So in manufacturing, you have a customer, you have someone delivering the thing, and you need to not go bust doing it. And that's the same in healthcare as well. It's just that the lens of the patient could be amplified. The lens of the factory analogy is amplified because it's a human, a very skilled human doing the thing they're doing, their clinical medical intervention, as opposed to a press knocking out something at a kind of rate per minute. But they are fundamentally the same principles. We're seeking to delight the customer in whatever way we can, and they are customers at the end of the day. We do it as effectively as we can, but we've got to do it with the resources we use to do that have got to be realistic. There are studies. You could spend the GDP of the country delivering healthcare if you wish. We can't do that. We don't use the R word, rationing. We don't use that word, but there is a trade-off. If you ask the public would say that heart and lung transplants for babies would be a top priority, and smokers should be left to wither and not get treated. It's a pretty hard view. That's the public. The government, our leaders, temper that and make sure that spending is allocated around. And there's a whole separate debate about lifestyle-led disorders that then the taxpayer picks up the cost for fixing. That's for another podcast, maybe.
Yeah. Well, I like a bit of controversy. They've really had some spice to it. Steve, what do you think world-class operational performance and excellence in healthcare would look like? Is there something that you would just know, we're there, that's what it would really be?
So I think it's to mirror what Jeremy said. It's customer. We don't talk about customers, we talk about patients, but we should. It's customer satisfaction and putting the care around the patient. So what's happened with any organisation is 70, 80 years of the NHS, the organisation has morphed. It's got bigger, it's got more departments, it's got more central departments, etc., etc. It's put on sticking plasters where things have gone wrong and audit functions and other things. So the beast is now quite big. And unfortunately, our patients, our customers, have to fit the system. So if you are a complex patient with multiple illnesses or long-term conditions or comorbidities, you will be bounced around the system rather than your journey is quite a smooth one and we put the provision around the patient. So we've kind of got to get back there. And there is a desire to get back there with the 10-year plan that's just been released at the end of last year, and neighbourhoods and things, is what do our neighbourhoods want? What do our patients and population within the neighbourhoods, because they're not all patients, want? And therefore, what provision of services are we providing? And then back to Jeremy's point, how much is that going to cost and can we do it? So long-winded answer to your question is we've got to put the patient at the centre of healthcare and population health and work out what does that population need. And I give some, examples of if I'm in a metro city like London or Birmingham, my needs are very different and my population is very different to a leafy village out in the middle of the country somewhere. So the provision, the funding, the demographic of the patients, the care they need, the services we need to provide, both proactive and reactive, will vastly differ across those two settings. You then weave in things like ethnicity and deprivation and other inequalities of healthcare, and you get a very different picture. So but we're not managed like that. The NHS is fairly vanilla. It has to provide for everybody in every setting, and therefore we try and provide everything to everybody, but not necessarily tailor it to the local population.
Yeah, can I come in there, Darren?
Yeah, sure.
I really agree with what Steve's saying there. One of the challenges for the NHS is strategy is about choices, and strategy is about what you don't do. And too many organisations, I have a very real world example that I was talking about yesterday in Northwest London, is not everybody should be doing everything in the provision of the healthcare. And historically, everyone wants to, every hospital wants to be able to do all the things that it could do and offer the latest technology to its medics and feel that it can offer everything. But you have to decide, actually, no. Years ago, they bit the bullet on stroke. So the stroke service, you would go past the ambulance would go past the nearest hospital, actually, because it's going to a stroke centre where your survivability is greater but you are traveling further to get there. Now, hats off to whoever drove that, because it worked, and it embedded the principle that it's not just about being 8 minutes away. There are people, you can look at some of the crises that have happened, the scandals that have happened in recent years. You've got clinical teams, they're not doing enough work in that clinical area to make it safe.
Yeah.
And that's not fair. That's not fair to the population. On paper, we offer the X service. Yeah, but maybe you shouldn't be doing that. And we have a real case locally. Well, I can't name the service, but it's done really quite well over here, and perhaps not so well over here. Well, the place, we've got to level up. And the place that's doing it not so well either does it better or doesn't do it, and this place does it on behalf of others. And that's real strategy, and that's real choices. And go back to post Second World War. Actually, it's health for all, and the demographics were different, long-term conditions were different, longevity was different, lifestyle was different, and things have moved on, and we have to be able to make those choices in order to be. It's no good doing everything and then running at massive deficits, and the whole thing falls over.
Jeremy, I'm going to stay with you for the final question because we're running out of time, and it really comes back to what you've been saying, right? So we know healthcare needs to make a shift. What's stopping it? And also, we live in a world where everybody knows it needs to change. We know it needs to improve. We get that from the top, from the health secretary right down. But then transformation and improvement budgets are not being ring fenced. They're classed as discretionary. So guess what? They go by the wayside. What is fundamentally needs to change to make sure that this is front and center and delivered?
Yeah, focus on just a couple of things that you're seeking to achieve and relentlessly drive them. There are too many decision makers around. There are too many senior people, bright people that care, but there are just too many of them in the mix. And it takes good, strong leadership to say that's what we're doing in order to achieve this thing, back to the problem that you're seeking to solve. That's what we're doing. This is why we're doing it, and we're getting on with it. That's great. We're going to do that in year 2 or year 3. Shift left is the latest chat. About moving it into the neighbourhood. Okay, that's fine. What does that actually mean? I've been through this locally. What are we actually doing? High deprivation neighbourhood. Okay, I get that. People in their long-term conditions that are frequent presenters at A&E. Okay, understood. That should be a primary care thing. There could be an intervention. There's work you can do there, because that then mitigates the presentation at the hospital. So attendance avoidance is a real thing for the acutes. So that's where I would go. Shift left is attendance avoidance, and ultimately admission avoidance. It's the same thing that we talked about 10 years ago, but it's just reframed slightly. But the intellectual fascination has got to move into the actual action. And sometimes the delivery of that care is best done in the acute setting. An MRI is not cheap. Do we stick it in a clinic in the neighbourhood? Well, funnily enough, most hospitals are in the neighbourhood. They're not built in a field on a business park. They are in the community. And let's have that conversation. Look at the demographic clusters. Look at the conditions and go, okay, how do we treat that? Polyclinics, fantastic. Diagnostic centres, fantastic. They can take a lot of strain away and run them hot, run them on shift patterns that are more akin to industry, and hire accordingly, reward accordingly. Set it up like that. Sorry, long answer, but that's
no, that's great. That's been great, Jeremy. I think you've summed everything up really perfectly. We have run out of time for this, but whether you're whatever you're doing to improve the healthcare in your organisation, if you're shifting left, you might want to put your camera up to the right. We've got a QR code to talk about more that Develop Consulting can do for you. Thank you for listening to this Improving Healthcare podcast. Thank you to my guests, Jeremy Butler, Steve Boam. Click on that. You'll find far more of this series. You can learn more about what you can do in healthcare, and certainly as well what our sponsor Develop Consulting can do in acute, primary, mental health and social care, really bringing the change that you need and our patients need. So if you've got any burning issues, you want to come on at one of these, or you've just got comments, or you want us to ask certain questions of certain people, do drop us a line and a message at info@develop-consulting.uk. Thank you again for seeing us. We look forward to seeing you soon. Go to wherever you get your podcasts, whether that's Spotify, etc. Click on them and share them with your friends. Look forward to seeing you next time.